Good afternoon. Welcome. As people are hopping on here, I'm just gonna do my little introduction here. My name is Renee Calkins. I'm the education manager here with the Michigan Center for Rural Health. The Michigan Center for Rural Health is a nonprofit state office of rural health, and a cornerstone of our office is to provide free education to rural healthcare providers. I will be the facilitator of this program, and I would like to welcome everyone to today's Nursing Grand Round. This program is jointly provided by the Michigan Center for Rural Health and the Michigan State University College of Nursing and the Michigan Social Work Collaborative for continuing education. This session provides 1 hour for social work, and physicians can self-claim this hour, as well as I would like to introduce Adrienne Wilkerson from the Michigan State University College of Nursing to continue with this professional development information.
Thank you, Renee. So as Renee said, this activity provides 1 contact hour for these various professions. Nurses are included in that. So you get 1 contact hour of nursing continuing education credit. Our accreditation statement is listed on the screen for you to see. We are accredited through ANCC directly. And the next slide, thank you. So criteria for successful completion today is that you're participating in the learning activity as best you can, logged in and attentive and active in it. That you complete that post-session evaluation survey at the conclusion of the session. Renee will share that at the end. We'll share the link in the chat and a QR code on the screen. We do ask that if you're able, that you complete that survey right after the event is over, just because that's when content is freshest in your mind and you're able to give the best feedback. It does also kind of help us to just facilitate closing out our activities in a timely manner. But we do understand that that's not always possible for everybody. So the evaluation does stay open for a few days still for you to complete. And then commercial and financial disclosures are that no commercial interest is associated with today's activity to disclose, and that no one with the ability to control content of the activity has a relevant financial relationship with an ineligible company to disclose either. And then next, thank you. So then our learning goal for you today, we hope that you'll be able to report increased knowledge of bias in pain management and prescribing. So it's pretty straightforward, and I'll hand it back to Renee.
Thank you, Adrienne. And with that, I would like to introduce our speaker today, Catherine Kowalski. Oh, excuse me, Kowalski. Dr. Catherine Kowalski works for Michigan State University as an assistant professor and is a nurse planner. She received her BSN from MSU in 2015 and went on to obtain her doctorate in nursing. Nursing practice with a focus in adult gerontology acute care from Rush University in 2020. Her clinical background stems from in emergency and trauma care, as she worked in emergency settings in Chicago, and most recent burn trauma in Detroit as a nurse practitioner for Wayne Health. Katie has a passion for education and continue to strive to better the nursing field in excellence and quality. This is shown through her commitment and leadership in varying education committee involvements, mentoring of nurses and residents, clinical faculty, and awards for education in the local and state level. Thank you so much for being here today. We truly appreciate your time and your expertise.
Thanks so much, Renee, for that warm welcome. And I'm really looking forward to sharing the next hour with you all. So let me just get set up here for a second. Okay. Can you guys see my screen?
Yep, looks great.
Okay, perfect. Let me just turn off closed captioning. Okay, so again, thanks so much for the warm welcome. Today, I'm going to talk to you about understanding pain bias in pain management and prescribing. So let's dive in. All right, I want to start by gauging your current confidence level, and kind of if you want to open this up in the chat, if you truly want to take yourself off mute, I'm just going to ask you this confidence question to start our session. So how confident do you feel in identifying bias in pain management? Just so you know, there's no right or wrong answer. This is again just measuring baseline to at least kind of get to know what you guys are really thinking about, how you feel deep down about kind of underlying bias in pain management. Wonderful. So I'm kind of seeing varying across the board, kind of medium scores, some lower, some higher. So I think this will be a really great kind of conversation to really just start our lunch hour. All right. So our objectives today. So we're going to be defining pain, differing types of bias within pain management and how it impacts. We're going to discuss pain guidelines and how social determinants of health play a role in pain management. And then we're going to analyze some strategies to help mitigate that bias and help eliminate health inequities when it comes to pain management. So this is a depiction from the CDC that outlines 3 areas of pain. So we're looking at acute pain, subacute pain, and then chronic pain. And most of these kind of definitions are based around a duration of time. So acute pain is nearly a universal kind of experience. It's more sudden onset or time limited to the patient. And again, it's usually less than 1 month, often caused by a trauma, injury, maybe a medical treatment like a surgery. And then we get into the subacute category of pain, which is a little bit more of the unresolved acute pain. It's usually present for 1 to 3 months, and then this can kind of start to evolve into our chronic pain category. So chronic pain typically lasts greater than 3 months. Usually it's from an underlying medical disease or a condition, right? So it could be an injury related to a trauma that has extensive rehabilitation. It could be something involving medical treatment, could be an inflammatory disease or process, right? Or something of an unknown cause. So why is pain important to us? Why, as healthcare providers, should we care about pain? Well, there are some pretty compelling statistics out there that are related to pain and kind of why it's a global health priority. So between 1/2 and 2/3 of people with chronic pain are less able or unable to do normal activities such as exercise, sleep, perform household chores, attend social activities, drive a car, walk, right? Many patients experiencing chronic pain have strained relationships with family and friends, right? An estimated 50 million adults in the US experienced chronic pain in 2016. It has since increased by 1.6 million adults in the last 5 years, making it 51.6 million adults in the year of 2021 that have chronic pain. This is a huge population. And some of these patients are even categorized further into kind of your high impact chronic pain realms, in which we're talking about that they report their chronic pain having restrictions on their daily limits of activities. And among these individuals, non-Hispanic American Indians and Alaskan Natives, as well as adults identifying as bisexual or adults that are divorced and separated, are of the highest within that category of the high impact chronic pain. And then, of course, we always have to talk about healthcare costs, right? So costs related to pain can range from 560 billion to 635 billion per year. And those are additional costs that we need to kind of consider are things like to the patient of missed days of work, hours of missed work, lower wages that are impacted by this. We also need to kind of consider how this might work for the patient in their work environment if it's debilitating to their everyday living. Okay. The cost of pain was more than that of heart disease and cancer treatments. So truly, there is a really global kind of focus on a health priority and kind of how we can bridge some of these gaps for pain. So I want to start kind of get off in the mindset of patient care and pain kind of through the lens of implicit bias. So I want to start with an activity. So I'm going to give you a clinical scenario, which is on the screen, but this is a shell. What we're going to do is we're going to kind of build upon this and change it a little bit. And the intention of this is for you to kind of reflect on your own practice, your own thoughts, differing questions that you might have or that pop up into your mind. Now, I want to preface this activity with that this is a safe space. This exercise and this presentation are mainly to help you focus and think and grow in your approach to pain to be more inclusive as well as more equitable in kind of in your approach. Feel free to share your thoughts and feelings, your emotions with the group, but also feel free to keep them to yourself and sit with those thoughts. All right, so clinical scenario that we're going to build upon. So patient is admitted overnight for a right femur fracture caused by a traumatic event. They're rating their pain 8 out of 10 and last received Norco 1 hour ago. The plan is for an ORIF tomorrow with orthopedic surgery. So does anybody have thoughts on this kind of brief report? Again, do you think anything of the pain, anything of the rating or the management plan? Yeah, I see a few things in the chat. Acute onset of pain may require more meds. Definitely. Norco is not enough to manage this pain properly. Okay, awesome. Thanks for participating too.
This
Few
is
more
Erica
things.
Sheffield, and I've been out of clinical for a while, but I think just how I would approach it is, reviewing the pain management plan with the patient. So making sure that they're clear on the plan. And then if it wasn't working, then we would already have sort of a frame of reference to work from, right? And sort of discussing what the plan looked like, talking about their expectations, sort of these are the orders I have, this is how we can manage this. But so I think starting with making them aware of what the plan is.
Yeah, yep. And some of your fellow people in the chat said, make sure that they understand the pain plan. You guys are on the same page and kind of have the same goals and priorities in mind, right? What's the patient's experience with opioids, right? Sorry, lots of messages coming in, so this is great. Not able to read them all, but these are really great kind of starting points for this exercise. I'm going to kind of move into the next shell just to kind of get our minds keep working and thinking through. So what if I gave you a little bit more detail and told you that this is an 87-year-old male with a history of dementia, admitted again overnight, right femur fracture, and this time it's because of a traumatic fall. Again, 8 out of 10 pain, last received Norco 1 hour ago. Plan is ORIF tomorrow with orthopedic surgery. So again, I'm kind of framing the same questions and again, relate this to a little bit about what we're talking today about with bias and pain management. But did anybody's perspectives of the pain change? Do you feel differently about the pain? About how you would manage? About the rating? Anything about the scenario? Okay, so someone said they'd be concerned about the verbal report, perhaps maybe better assessment using kind of a pain score, not differently about the pain, but needing to be careful with further narcotics because of age. Aware of bias with dementia, one could argue. Does the patient understand the question, right? Have we even established, what the pain scale is? Are they appropriately rating it 10 being the worst or 1 being the worst, right? Kind of in that. Curious about pain threshold before the accident? Of course. These are all really great things. Risk of delirium. And I apologize if I'm missing your comment, just things are coming through so as I can read it quickly as possible. Have we addressed their ability to hear? They wear hearing aids? Yeah, that definitely impacts kind of your ability and your management plan with this specific population, right? Okay, and then, like I said, we're going to continue building, so we're going to change up the scenario just a little bit here. But what if it was a 24-year-old female with no past medical history? Again, admitted overnight for right femur fracture, and this was caused by a motor vehicle or motorcycle accident. Urine drug screen was positive for cocaine and barbiturates. Blood ethanol level was 142 upon admission. Again, same rating, 8 out of 10. Last received Norco 1 hour ago. Planned for surgery in the morning. Again, asking any perceptions and changes in the way that you feel about the pain. Maybe about the rating, the management plan, the overall clinical picture for this patient. Did anybody's kind of perspective change on things? All right, assess nonverbal behaviors. Okay, let's see. Concerns for pain medication interactions with drugs that might already be in the system. So traumatic femur fractures would require acute pain management, but realizing use of substance use disorder possibly, right? Drug interactions, for sure. So I think it's okay, and I'll kind of wrap up this exercise, but it's okay to have differing thoughts and differing approaches to these patients, because I would treat and manage their pain with differing approaches just based on the patient themselves, the assessment, the needs, right? The overall goal for the pain management. But what I wanted to do is take a moment to see if anyone had any thoughts that maybe were conflicting, maybe something that changed your attitude or judgment. Maybe you felt more of a connection to a certain patient or of the scenarios based on kind of your past lived experiences, your patients that you interact with every day, or, maybe your own self experience, right? But this kind of leads into our focus for today. So let's talk a little bit about bias. Bias is an evaluation of something or someone, and it can be either negative or it can be positive. So implicit bias, or kind of that unconscious bias, is where a person's really unaware of their evaluations and their biases, right? So a person might think that they're treating everyone equal. However, their unconscious bias kind of have that negative association that an individual might place on a person's certain group or people. And it's the negative implicit bias that is particularly of concern when we're talking about healthcare and within our healthcare field. So explicit bias, we're talking about you're aware of these feelings. You're aware of their conscious thoughts and your awareness to the thoughts and feelings that you have towards people and groups. And then the other one that I like to bring up kind of in the healthcare realm is confirmation bias. And that's kind of where you're seeking and accepting only information that kind of confirms a diagnosis rather than the information that might refute it. So an example of this is where you kind of get yourself caught where, right, you have a patient that has left-sided chest pain and they have a positive troponin that comes back. You're automatically thinking heart attack. You kind of lose sight of all the other differentials that could potentially be there, right? So bias can have a major impact on the way that we as nurses or clinicians kind of conduct ourselves within consultations and making decisions with patients. Often, again, bias is unintentional, but it doesn't diminish the fact that there are definite consequences it can have on the patient. Failure to treat pain and poorly treated pain can interfere with how a patient recovers from their illness or their procedures, right? And that in turn can lead to further safety issues, financial consequences, such as increased length of stay in the hospitalization, readmissions, increased morbidity, liability exposure. And then often bias in pain management can kind of lead to misdiagnosis or unnecessary suffering of a patient, mistrust with healthcare providers, and failure to kind of provide that patient-centered care. Again, we're not always aware of any personal or institutional level biases that might be within our care organizations. And so that's why it's really, truly important to kind of have these discussions kind of going forward with how we can better treat pain. So what does bias look like in healthcare and pain management? So again, pain is recognized as a global health priority, and as part because of the long-standing health disparities that have kind of been within pain treatment all along. So what does this look like? So racially, Blacks and Hispanics are less likely than whites to receive pain medication for acute pain. Blacks have less referrals to pain specialists on average and receive lower dosages compared to white patients. Gender-wise, women have a higher risk for inadequate pain management, but have a higher prescription fill rate than men. Black, Hispanic, and Asian women, they often receive fewer postpartum pain medications and assessments when compared to whites. Geographically, right? So thinking about our rural communities. Persons living in rural communities are more likely to have opioids prescribed for non-malignant chronic pain. Misuse of opioids is more common within rural areas when compared to metropolitan. And then compared to kind of your urban residents with chronic pain, those with chronic pain in rural areas are less likely to use non-medication therapies, such as physical therapy, yoga, kind of your basics, heat, ice, things like that. And they're less likely to, or they're more likely to use 3 or more types for chronic pain management when it comes to medication use. Socioeconomic. So for acute pain in an emergency department, patients with lower socioeconomic status were 24% less likely to receive an opioid medication. And then compared with higher socioeconomic patient, those of the lower socioeconomic levels are 63% more likely to only receive an opioid for chronic pain instead of opioids plus any non-pharmacologic or non-opioid pharmacologic treatment options. And then kind of age-wise, some healthcare professionals kind of act in an age discriminatory way by dismissing older patients' pain as kind of inevitable, right? Part of the aging process. So what are things that we need to focus on as nurses, clinicians, providers, right? Social determinants of health are the conditions and the environment in which a person is born, we live, we learn, we work, worship, and kind of how they age and how that affects their health and quality of life. So there's 5 domains, as you can see on the right-hand side image. And social determinants of health, they contribute widely to health disparities and inequities. So we as nurses need to develop a greater understanding of the social and environmental factors that are related to differential outcomes for individuals that experience persistent pain as well as disabilities when it comes to pain, in order to kind of achieve health equity. The foundation of providing good access to care and delivering high quality care in pain management is understanding how these social determinants of health influence a healthcare provider, and the differential kind of outcomes that you can have, right? So social, economic, educational, neighborhood level factors, they all might contribute or exacerbate health inequities when it comes to persons that experience throughout their life. Historically and contemporarily, injustices that have advantaged some and disadvantaged others in society can lead to then that marginalization and oppression of groups. So, and of these inequities, affected both by racial and ethnic groups, women, persons living in rural communities, persons experiencing homelessness, persons with disabilities. It's really important that we impact these social determinants of health when we think about how we prescribe and how we manage pain. So this was a study that I found in the Journal of Pain that looked at social determinants of health and patients with persistent low back pain as well as persistent pain following a spinal cord injury. So the aim of this was to develop insight on how the rules of social determinants of health impacted the patient's kind of experience and then their overall health status related to their socioeconomic kind of the disadvantaged adults. So there were 164 patients that completed the survey and conducted kind of a semi-structured interview. And as you can kind of see in the table, the representation kind of summarized the adverse social determinants of health most commonly reported by the participants. And those were things like unemployment, inadequate social support, persistent financial strain, or limited access to transportation. And I just find this really impactful to consider because there's not always the thing that's not always the thing that we focus on as nurses or providers when thinking about the pain management plan. But rather we need to get deeper and not just think about the diagnosis and the prescription, right? We need to understand all of these underlying factors and how they impact how the patient's pain then lives within their life, right? Especially how it impacts the community we serve. If patients or our patients live far distances away from the care teams or their specialty services they're following up with, if they don't have adequate access to pharmacies or pharmacies that carry medications that they need, these are all things that can gravely impact the way that we can treat pain to our patient population. So we're going to take a little bit of a pivot, and before we start talking about the CDC guidelines, I wanted to take a minute to think about a little bit more about your pain experiences and the relationships you have with your patients. So there is a raise your hand feature, but you can also put your thoughts in the chat too. But have you ever thought a patient overreported their pain score? How many people feel that people underrate their pain? Yes, both. Okay. I'm kind of monitoring hands and chat. And then, do you feel like patients are often truthful when they're describing their pain or how they feel? Sometimes 50-50. Yeah. I know, you never know. But this is why I bring up these questions is because the treatment of pain is really unique. Okay? As nurses and as providers, we feel really good, or at least I do, feel really good about a concrete patient data, right? That can help support my diagnosis. And I feel really good when I have objective findings to back myself up. So, example of this, diabetes, right? So there's objective findings and diagnostics that you can use to kind of help support and guide your management plan, right? You can take a blood sugar, you can check an A1C, but and those kind of help you understand, the overall disease state, the progression, maybe what their compliance is. But I think the truly really difficult thing about pain management is there's no true objective findings for a clinician to use. More so, pain is mainly reliant on subjective data that the patient gives you. Now, I'm not saying that there's no observational or objective findings. Okay, they could appear comfortable or tense or grimacing on assessment. But I mean that there's no the true representation of pain lies with what the patient tells you. So why am I asking you these type of questions? Well, I think a lot of what we're going to talk about within the guidelines reflects back to our patient relationship, the way that we individualize their treatment, the assessments, the conversations that we have with the patients to help make up our treatment management. And then how easily bias can kind of come up within this process. And again, because there's no true objective findings, how easily it is for some of those assumptions and judgments to just, again, come up into some of the things that we consider when talking about pain management. So there are differing pain guidelines out there, depending on what area or specialty you work within. But kind of for the sake of time and content, we're just going to be diving into the CDC guidelines that kind of speak more to outpatient management of acute and then versus kind of your subacute chronic pain. So the CDC saw that there was a need for a national guideline. And this was based on kind of improving prescribing measures, as well as kind of mitigating and minimizing risk and injury to the patients. They were originally published in 2016. They had some concerns about misapplication of some of the recommendations initially, so they re-updated and made revisions, and they were republished in 2022. So of that, there's 12 recommendations in total, and then there's 4 categories. So I want to say too that each of these recommendations could almost be a talk of their own, but I'm going to go over the big picture items and kind of the takeaway items for nurses that can kind of help impact, improve your pain management and treatment of patients with pain. All right, so our first category is determining when to initiate opioids for pain. So this is both recommendation 1 and 2, and I kind of melded these together because overall, like the components of those recommendations kind of were similar and overlapped. So recommendation 1 leans into the acute pain side, and then recommendation 2 looks more at that subacute and chronic pain. So how do we, as nurses, as clinicians, determine when to initiate opioid therapy? So that really, we need to start with the foundation of a really good history. And that's the building blocks of establishing your patient relationship, right? So we need to take a really good and thorough history on our patient. And this includes characteristics of the pain, but also contributing factors and things that kind of go outside of just the pain, but livelihood too, right? So function, your work history, current work demands. Are there any psychosocial stressors for the patient currently? How does this impact their sleep, right? We're looking at the physical exam too, and maybe there are some images or other diagnostic tests that may be indicated at that time. But we're looking at the recommendations. So the recommendations say that non-opioids are at least as effective as opioids when it comes to acute pain. For subacute and chronic pain, opioids can be preferred. But for both acute and chronic, we need to maximize our non-pharmacological approaches, right? As well as our non-opioids. So things like physical therapy, massage, acupuncture, yoga, mindfulness, and then considering alternative or adjunct therapies, right? So NSAIDs, acetaminophen, nerve medications. And then we always want to make sure we're using kind of that multimodal approach that incorporates other modalities to help share in your treatment plan. And then once you've decided, after kind of weighing those benefits and risks with that patient, that it's time to start opioids, we need to have what I think is kind of the most important step in prescribing and safely medicating a patient for pain. And that's having that in-depth discussion about what the treatment plan looks like. What are the benefits? What are the risks? What should they expect? And then what should they expect for the duration of the medication? Because if you're not upfront and kind of set those realistic expectations with your patient at the start, then there's going to be kind of confusion and maybe a little bit of mistrust toward the end when the patient doesn't feel as if you're meeting those kind of demands, and if you haven't had those upfront conversations about what the expectation and what the overall kind of overarching themes are of your pain treatment plan. So now that we've kind of looked at recommendations 1 and 2, I want, and that's kind of like again, that determining how, or determining if opioid therapy is necessary. But I want to propose that we apply what I want to say a practice check, that equity lens. Okay. So looking through a health equity lens, how can we best approach initiating opioids? So again, this starts with the foundation of the nursing and patient provider trust relationship, right? We need to make sure that we understand our patient. We understand their background, their culture, their values, but we also need to understand their pain. What's important to them? What does a day with minimal pain look like to them? What do they hope to gain from treatment? And then how can we best approach this? So patient education and discussion before starting opioid therapy is vital in understanding, one, again, the patient preference and values, but that then leads to that informed clinical decision making. There was kind of an interesting study that I was reading that kind of looked at the use of complementary, like self-management interventions such as yoga, music, things like that. And it was actually significantly different between the rural population and non-rural residents. So non-rural residents indicated that they used self-management strategies 92% of the time, whereas rural patients only sought out to use alternative measures 75% of the time. And in addition to that, for opioids, 76% of the rural population was taking opioids within that study, whereas only 52% of populations or of the non-rural population was taking an opioid, in addition to those self-management strategies. So when we consider what medications to start and the approach to the management plan, again, from all angles, we really need to consider the education, both on the pharmacological side, but also on the non-pharmacological options that we have for our patient treatment plan. We also need to review any low-cost options for pain management for all patients, but in particular, let's consider our patients with low incomes, patients that don't have health insurance, patients that might not have inadequate health insurance, right? And then we need to be aware and make sure our patients are aware of all the expected benefits, common risk factors, serious risk factors, or side effects, alternatives again to opioid therapy before starting and or continuing on with therapy. And then the patient should truly be involved in the decision, whether it's to start an opioid therapy and start to set expectations and really truly measure out that timeline of how long the treatment plan will last and what their kind of expectations are for a week, a month, 2 weeks, right? So that you guys can establish that trust early on. So moving on to the next domain, we're looking at selecting opioids and then determining the dosages. Okay, so again, I'm not going to dive into specific drugs, classes, adjunct therapies, dosages. I'm going to talk about the main takeaways from these domains. But what I did want to provide to you is this conversion table over on the right, which is the morphine milligram equivalents for commonly prescribed medications. And I think it's really relevant as nurses, as providers to know, especially when discussing and prescribing medications. It's really vital that you consider what a safe dose is and then the conversion between if you're possibly switching dosages for a patient and what would be similar dosage to a differing drug and or safe for that medication. So recommendation 3, main takeaway is that you always want to start an immediate release medication versus an extended release. In 2014, the FDA modified the labeling for extended release medications, noting that there's serious risks and recommending that extended release opioids should only be reserved for management of pain that's severe enough that it needs around the clock, daily, 24-hour long-term opioid treatment. And then again, this is when alternative options are either ineffective, not tolerated, or otherwise inadequate. Also, extended release medication should never be prescribed and or given as an as needed medication. Recommendation 4 talks about kind of your opioid naive patients, but frankly, any patient, you should be really prescribing the lowest and or administering the lowest effective dosage for that drug. For patients not already taking opioids, the lowest effective dosage can be kind of determined. Again, you have to lean into your resources that you have available, depending on your facility, the pharmacies that you work with, things like that. You can use product labeling, other applications and services for kind of referencing, such as like Lexicomp, Epocrates, UpToDate. Again, phone a pharmacy friend, right? Talk to a pharmacist about appropriate starting points for as needed basis. Again, dependent upon the severity of pain, but other clinical factors such as your renal and your hepatic insufficiency. And then recommendation 5, we're kind of leaning into patients who are already on opioid therapy. Again, looking at the benefits, the risk to the patient, especially when changing the dose. We're still trying to optimize those alternative therapies and then non-opioid therapies. And have you considered a multimodal approach? Again, involving things like physical therapy, right? For patients that may qualify. Non-opioids, ibuprofen, Tylenol, other adjuncts, nerve agents, muscle relaxers. And again, then when appropriate, prescribe and or administer the lowest effective dose of opioid. Again, these are all things once you've kind of considered and you've optimized other therapies, you're going to try to work closely to then gradually taper or reduce your opioid dosage for the patient and or discontinue the opioid therapy altogether. So again, this is a shared decision-making and partnership. And that's kind of what truly will make you successful in tapering medications, because if the patient is not willing and or participating in the taper, then you're not going to be very successful in your plan. So the goal of tapering, it may be dependent upon the patient on how long they've been on medication, their specific pain needs, their functions, and so on. But essentially, you want to start the taper. And what you want to try to achieve is the smallest dosage range possible first, and then you would kind of expand how often or frequent the patient is getting a medication. So example, take oxycodone, right? So you got oxycodone 10 to 7.5 to 5, and the patient was taking it every 4 hours. So you gradually get them down to that 5 milligram of oxycodone every 4 hours, and then you start spacing out to 6 hours, 8 hours, twice a day, and then daily. You can then take a patient off and or discontinue an opioid once they're kind of to that BID/daily dosing. So another practice check time. So let's look at, again, how we can use that equity lens to help kind of direct our pain treatment approach, especially when it comes to kind of dosage selection and opioid selection, right? So again, this starts with an individualized approach. We need to really understand our patient, their experience, their pain. Pain guidelines, they're not a standard, like a rigorous standard of care. They can't be a one size fit all for the patient. You have to approach it in an individualized treatment approach. Again, and we as nurses and providers can use these recommendations as a guidepost to kind of help, again, that informed clinical decision making with the patient at the center of the approach. So how can we do this? So We can help use periodic and strategic motivational questioning, help encourage movement toward appropriate therapeutic changes and functional goals, right? We need to be having these discussions with patients at every appointment and making sure that we're still directed at the same kind of outcome and same goal for the patient and the pain. As clinicians, we have the responsibility to provide and arrange a coordinated management plan. That means related to their pain and or opioid related problems. They have appropriate follow-up, they have appropriate support and resources. And, nurses can play a really vital role in kind of increasing effective teaching as well as effective use of kind of that self-management interventions too for chronic pain, right? So as we mentioned about the rural residents using less kind of adjunct therapies to pain for non-pharmacological pain management strategies, as well as making sure that the patients can safely and adequately know their dosing range, know their how often they can take them, the side effects, and really being those advocates for proper identification and education to our patients. As somebody who really likes to mitigate risk to patients, especially when it comes to opioids and kind of high dosage, there is no single dose threshold that you get to in which you risk your risk for injury and or harm is eliminated. So it's important as nurses, advocates for the patient, providers, that again, we're weighing those risks and benefits to the patient when it comes to starting and or increasing any dosages or discontinuing, right? Because we want to make sure that we're doing that safely as well. And then understand that the focus is again that shared decision making, which is in particularly important to the patient. All right, so moving forward, we've decided, so now we're deciding duration and kind of conducting the follow-up with our patients. So again, we're under the assumption that most acute pain will often be managed without opioids. But when acute pain does require opioid therapy, a clinician should be prescribing no greater quantity than that is needed for the expected duration of the pain. And that's based on kind of severity to kind of get you to that point in which enough of the medication is prescribed for what is required. So again, this ties back into kind of recommendations 1 and 2 about how opioids should be started at their initial starting. We need to set expectations and give that bigger picture to the patient on what the pain management goal plan looks like, so that when the patient gets a prescription for a pain medication that's a week long or 2 weeks long or a month long, they have kind of that appropriate picture and have agreed upon this plan based on the kind of expectations of the of what their functional goals are and what the duration of their pain is going to be like. And then again, making sure that they have appropriate follow-up. Duration should be individualized for the patient, dependent upon their clinical circumstance. And then recommendation 7 is more about follow-up. So for any acute pain, patients should be reevaluated at least every 2 weeks if they're continuing to receive any opioids for acute pain. And then for subacute pain and chronic pain categories, patients should really be evaluated at least every 3 months, but truly it's those patients with higher risk for opioid use disorder and overdose. So patients with mental health conditions or depression, patients with a use of history of substance use disorder, a history of overdose, or anybody taking greater than 50 morphine milligram equivalents daily, or in addition with any other central nervous system depressants, they should be more frequently than every 3 months. And as clinicians, as nurses, we should be regularly screening all of our patients for these conditions and any changes during their course of treatment. So another practice check for us, but we're looking at, again, the equity lens. So we have this wonderful individualized patient approach. We're kind of at the point of follow-up with this patient. We should be reviewing the patient's perspectives and goals, but we need to kind of determine whether or not the opioid is continuing to meet their treatment goals. It had sustained improvement on their function, on their pain. We need to determine whether or not the patient has experienced any common or severe side effects. And are there any early warning signs for adverse reaction or other signs of opioid use disorder? At this point, though, it's really vital that we stop and we consider social determinants of health. How does this impact our perfectly tailored plan for pain, and especially when it comes to our rural population? So, does the patient have reliable transportation to get to and from treatment and follow-up? What's their nearest pharmacy? And does that pharmacy even have the medications that are being prescribed to them? Do they have medical professionals near them? Or are they being referred to a specialist or a referral physician that might be far away? Can they afford medications being prescribed? Do they have insurance? Do they have support? Do they have family, friends, right? Pain is a huge burden. So we have to also then consider the health literacy and their understanding of the education that we provide as providers, right? So what are other things that we need to consider? We also then need to look at the patient as the whole patient. Pain has other many contributing and associating factors. So we should be screening for things like depression, anxiety, any other psychological condition, comorbidities. We should be referring to psychology or psychiatry to kind of help optimize and care for the needs, and then refer to pain specialists. Again, we should always be maximizing pain with non-pharmacological and non-opioid pharmacology treatments as appropriate. A study I was reviewing was talking about kind of how to help with barriers with rural health and how telehealth can really help bridge the gap between kind of the nurse and provider to educate on optimal and safe pain medication practices such as opioids and self-management interventions. But in this intervention, it really can help with follow-up, coordination of care, and all of these really wonderful things, again, to bridge the gaps. But telehealth, again, can only work if your patient has access to it. So that's something else to consider, because I think it's estimated that 19 million Americans, including 1/4 of the rural resident population and then 1/3 of tribal populations, that still don't have necessary broadband internet to access things like telehealth. So that's always a consideration in how we can kind of mitigate. All right, so our last domain, we're addressing risk and harm. So recommendation 8 discusses how we offer how clinicians should offer naloxone when prescribing opioids, and particularly patients in an increased risk for overdose or patients with history of overdose. We need to be kind of really focusing on whether or not you give a prescription for naloxone or have it available within the MAR, right? So naloxone prescribing and dispensing mandates kind of first came into legal requirements in 2017. As of January 2023, 18 states have actually enacted laws. But what do we have in Michigan? Michigan, we have a standing order that allows individuals to access naloxone through registered pharmacies. So as you can kind of see to the right, the map here, these are pharmacies that are currently registered and have met the requirement of the state to be able to distribute naloxone without a physician order. This is a huge public safety initiative to help address risk and harm. But now, as you see, the upper and kind of the upper lower peninsula have few and kind of scattered access and resources. And so again, this goes right back into those social determinants of health and health inequities, right? Goes back into those statistics for the rural population and kind of how they're more likely to be prescribed an opioid, but they have less resources and kind of higher risks of misuse. And again, leading further into the problem. I did include down there the family and patient resource. So Michigan Open is a website that you can go to for free resources for your patient. And they just have a plethora of videos, visuals, informational handouts, and kind of that walk you through the basics and best practice of naloxone, both for a nasal atomizer as well as an IM injection. So next we're going to look at recommendation 9, which is talking about prescription drug monitoring. And in Michigan, we have what is called MAPS. Okay, so Michigan Automated Prescription System. And this is kind of a picture of what a provider view looks like for drug monitoring. So there's the NARC score, which is divided into 3 categories: your narcotics, your sedatives, and your stimulants. The range is from 000 to 999. The last digit of a NARC score will equal if they have any active prescription. So in this example, you can see the NARC score ends with a 0, so there is no active prescription. But then it looks at indicators for things such as number of prescribers, number of pharmacies, milligram equivalents, any overlapping prescriptions. And a NARC score, it should raise concern for a patient, but it can't base your decision making. It can only kind of trigger that discussion point for you. Again, it's not an abuse score, but a higher score is associated with somebody who is more likely to exhibit some form of misuse. Then there's the additional overdose risk score. So again, ranging from 000 to 999. And an unintentional overdose death approximately doubles for every 100 points. Okay. And then a patient with a previous overdose automatically gets a score of 991, unless they've had multiple overdose events in which the last digit would equal the number of previous overdose. So if they had 3 overdoses, it would be like 993. There's also additional risk indicators that populate for prescribers, and that is when they've had 5 or more providers in any year. There's 4 pharmacies within any 90-day period. And then if there's more than 40 milligram morphine milligram equivalents per day, or more than 100 in total. So finishing up here, our last recommendation. So toxicology is a little bit controversial. It should not be used in a punitive manner, but rather should be used in the context of other clinical information and kind of to improve our patient care. So we should always aim to minimize bias in testing, and it should not be applied like on a differential basis on the assumption of patient. So I personally have never used testing in my practice. I've seen it regularly used. And that's more when I've referred patients to a pain specialist. And it's kind of like a standardized approach in which you're testing a patient upon arrival before you can give additional and or continued prescription therapy. Recommendation 11 is speaking to the caution for nurses and providers when we're looking at both opioids as well as use of central nervous depressants, such as like benzos. And then the last recommendation is kind of offering treatment for misuse and opioid use disorder. So detox is never recommended, but there's a stigma that can play a big role in the willingness of an individual to really seek treatment. So opioid use disorder, it's a chronic and treatable disease in which a person can recover and then continue to lead a healthy life. So if you suspect misuse or this disorder, approach the patient with a non-judgmental manner. Make sure that you provide them with opportunities to disclose concerns and problems, and then always assess the presence of a use disorder with a verified tool, something like the DSM-5 criteria tool. So our last application on how we can kind of, again, help mitigate bias and help approach health inequities in pain management. But this is kind of going back to reviewing the MAP score. So using specific drug monitoring information with the full clinical picture, including the patient's history, their physical findings, other relevant tests. Making sure that you understand that this is just a score and it does not take place of clinical judgment. And again, knowing that it helps us with communication with the patient, but also helps protect our patients. So if you are reviewing these scores and you see patterns of unsafe practices, discuss this with the patient. I've had a patient say to me that they've never taken medications before in the past, and I go out, I'm, writing up their prescriptions and something pops up on their maps. I've gone back into those patients and just approached them about the situation. Upfront, honest, but respectable, right? Tell them what you found. Listen to their explanation. Again, create and continue to build upon those foundations of trust. And when in doubt, knowing your resources, right? So, contacting a pharmacy about your regular prescriptions, noting how many prescribers they've had most recently, right? So, all of that information is available. And then maybe even consider inpatient treatment plans for anybody that you're really concerned about safety risk. And then also just making sure that you're checking yourself for use of stigmatizing language, because that can truly ruin the foundation of trust that you have with your patient. So we all know that documentation is really readily available to patients and open within kind of a lot of the electronic health records now. So if they feel judged or feel like that you've made assumptions or generalized viewpoints about them, they're not going to want to continue to work with you in a meaningful way. So things to avoid, right? So stigmatizing language, non-compliant, frequent flyer, drug seeking, abuse, right? Use the word disorder or misuse rather when that's being prescribed, and then use specific diagnoses, right? So substance use disorder or opioid use disorder. Again, I already kind of touched upon this in my last slide, but non-judgmental approach is the best way to kind of maintaining that foundation of trust with your patients. So super busy picture, but this is kind of how I wanted to sum it all up. There's so many things that stand out here to me: bias, privilege, diversity, inclusion, taking action, being an ally, right? Be an ally for your patients when you approach their pain. We as nurses, we have the responsibility to address health inequities, protect our patients' safety, prevent unnecessary risk. We have the responsibility to ensure access to appropriate, effective, non-pharmacological and pharmacological pain management approaches, again, that are individualized to the patient. It should be affordable, accessible, and well coordinated. And we need to strengthen that patient clinician foundation and that communication to establish that trust when providing education and kind of prescribing pain management and treatment. All right, and that is it for me. Any questions? And here are my references for anybody. But question time. I do want to say thank you so much for your time and spending your lunch with me. It's been a real pleasure being with all of you, and thank you for your participation and the little activities throughout.
Yes, thank you for being here today. We truly appreciate your time. If you guys do have any questions, please go ahead, either unmute yourself or type them in the chat. I am going to drop the evaluation here, and I will also share my screen with a QR code.
Oh, hold on. 1 second again. I will stop sharing.
yes, it was very informative. I loved the rural perspective, so I really like when we can include all of that within our grant rounds. So I appreciate you thinking in that lens as well. So thank you.
Of course, thank you. And thank you everyone out there for all that you guys do for your patients in your communities.
And I will have a follow-up email in case you have to hop off right away and are not able to send the evaluation. And so look forward to that this afternoon. And everyone have a great afternoon and thank you all for being here.